I'm going to talk a little bit about, how I came to be interested in IlluminOss as a fracture adjunct. So about 80% of my practice is fracture care, and also complications associated with fracture care. And I work at a level 1 trauma center here in Los Angeles. So we see a variety of fractures. And as we know, for fracture care, we're really interested about developing and growing our toolbox so we can address, we can continue to improve and address more and more challenging fractures with, similarly with fewer complications. So, as a little bit about me, I tend to be someone who's a little bit more conservative. I'm not always the first person to jump on the newest technology. And I saw some of my colleagues and I saw some of the cases that had presented. And I thought, well, this is something that's, I think, interesting and would be useful to have, because occasionally there are times when the traditional methods of fixation are not exactly what I need, or I think there could be something better. So I'm just going to talk a little bit about my thought process about with how I started to use IlluminOss and where I think it's going to be the most useful. So, and I'm mostly going to talk about periarticular fractures. That's the trauma surgeon's realm. I think we have great solutions for your typical diaphyseal fractures. It's hard to beat the results from an intramedullary nail for a femoral or tibial shaft fracture for the most part. And so where we're getting into are these periarticular fractures, periprosthetic fractures, things where our bone support, our bone stabilization methods can still, leave something to be desired. So I'm going to go into a little bit of the rationale between the importance of multi-columnar support, different things we've tried thus far, and where IlluminOss might fit into that role. So in general, multi-columnar fractures, for example, a periarticular fracture that involves both the medial and lateral columns here in the tibial plateau. And now we're recognizing the anterior and posterior aspects of the bone as its own independent column. They tend to need multi-columnar support. It's hard these days just to have one single implant. It's rare, I think, that is the only needed support, especially as we're trying to get better and better about early range of motion and early weight bearing. It's really not feasible, or I think acceptable for most patients, to be strictly non-weight bearing for 3 to 4 months these days, whereas it used to be routine. And I think we have better implants now for even immediate weight bearing. And I'm going to talk about that in a minute as well. So our goals for periarticular fracture repair: number one, we got to respect the soft tissues. We're not just carpenters, we're also gardeners, and we have to be sensitive to the soft parts of the body, not just the bone. We definitely want to restore coronal alignment, sagittal alignment, and balance, and ideally something that would allow for early range of motion and weight bearing as early as possible, especially as we start talking about patients who are more and more complex, like diabetics, kidney failure, or patients who are otherwise frail and elderly who cannot be non-weight bearing without serious detrimental health side effects. So here's a classic example, I think, a reasonable fixation. Well, starting with a relatively straightforward patient, a young, active, healthy guy skiing in Europe who had this fixed out there and came to see me. And again, we're just talking a little bit about the importance of multi-columnar fixation that's balanced. So he did have a medial plate. It's a posterior plate here. It's relatively flexible. Kept him non-weight bearing for 8 to 10 weeks and then let him start walking. And then, you can see here that he's starting to drift into varus. This is after 4 to 5 months. I think he'd been walking for about 5 weeks, and you can see here the plate is broken. So it's too flexible. It broke right at the fracture site. He's got a non-union. He's lost his mechanical axis. And in order to repair that, you need to go in, and traditionally you go in, you jack things open, you put some very stiff implants on that side, and there you go. So he went on to heal after that, approach. But that medial incision is no joke. Even in healthy patients, this is not that patient, but this is a similar patient. That medial sided skin incision, the skin bridge there, is pretty fraught with complications. It's can be very challenging. And so if there's a way we can protect that medial side or get that multi-columnar support, I think it's worth investigating, because these wounds can become quite complicating, needing flaps and a lot of, infection and a lot more complex, unfortunate sequelae. So, one way is sometimes the old ways are the best ways. You can just pick a super stiff one-sided plate. This is a list plate. It's been around since the 90s, was a revolution when it first came out. And even then, though, you can have a super stiff column on that lateral side, but unless you do something to that medial side, you can see here, it was well aligned and intraoperatively. And then as the patient started to weight bear, and you can see this bilateral total hips is an older patient, not very good at non-weight bearing. You can still lose that and drift. So, I'm a trauma person. I love nails. What about nails? It's the perfect alignment fixation device. It's intramedullary. It's along the mechanical axis. But sometimes when you have these short segment fractures, that even with suprapatellar nailing, blocking screws, all of that, it can still be pretty challenging because the nail is very rigid. The start site can drift, especially if the bone is very poor. So here's a patient who had a history of osteoporosis, as obviously as you can see here, also has dialysis, so it has some renal osteodystrophy. And so, we tried everything, a suprapatellar approach, even did a little bit of a parapatellar arthrotomy to move that patella over. And then even despite our best efforts, getting everything lined up with blocking screws in multiple planes, that start site almost always drifts a little anteriorly. It's difficult to correct that procurvatum deformity. Even with blocking screws, we're in terrible bone, and we are in, there's not a lot of back there that you can bounce the screw across. And she did go on to heal, but, it was not exactly the, fracture reduction that I wanted. I wasn't terribly happy with how it came out. So what if we do a plate nail construct? That's the thing that we're doing a lot now. We plate it first, get the reduction, and drop the nail down. And I think this is a great strategy, but it's technically very, very tricky. And there isn't a lot of room for error. Even when you do the best planning, and this is, again, another patient where they really needed a weight bear pretty much immediately because of their neuropathic. Where your hardware traffic can be, you lose out on your fixation options because it's very difficult to predict exactly where every screw is going to go and exactly where every obliquity goes, as hard as you may try. So that patient ended up doing well, but again, technically a little bit not exactly the way I wanted to go. I didn't get as much fixation as I wanted from both of those implants. So, an ideal situation for this additional intramedullary, soft tissue friendly multi-columnar support would be soft tissue friendly, would be something that maybe wasn't so rigid that it sort of pushes the bone around rather than allowing the bone to stay reduced. Something where your fixation options will not be lost because of multiple hardware. It doesn't box you out, and something structural so that you can allow for early weight bearing. And so this is usually what I'm thinking about when I'm trying to think, make my operative plan. So, and this is where I started looking at IlluminOss because it can be applied intramedullary. The start site is relatively small, as is the insertion process with reaming, and it's drillable. And honestly, that's really what I was looking for, is a drillable nail. I had looked into carbon fiber nails, which were close. But if you've ever seen what happens when you drill through a carbon fiber nail, it creates all this very, very dark black sludge, which I don't love. So if there's a way to get around that, I would prefer. So here we've got a patient who is a poorly controlled diabetic neuropathic patient who here has this very displaced proximal tibia fracture. So all the things that make a nail, even a nail plate, very tricky. Very short segment. The fracture line extends right up to the start site. So even with blocking screws and everything, it's pretty hard to maintain that start site exactly where you want it to be, and it may drift. He's neuropathic, so he's not going to be non-weight bearing unless you basically make him bed rest or, wheelchair only. So I thought this would be, a good chance to have something that meets all those criteria that we just discussed. So got his reduction, required an open reduction because he was so displaced and buttonholed. And interestingly enough, this happened from a stumble off of one step. So he'd had a couple of weeks of pain around the knee and then stumbled one step. So I think he had actually developed a stress fracture, and that's why it's so wildly displaced. And it may have broken even before he fell. So, we did a nailable X-fix. So a traveling traction, built up a bar across it so we could control that proximal tibial segment with a Shantz pin, and then locked that in, left that. Went to my plate fixation to hold the reduction so that I wouldn't push things around with the nail, but then backed out the screw so it would be away. So still some of the same technical challenges of an plate nail construct. And then this is where things got a little bit different. So rather than putting in a solid nail, using the IlluminOss as an intramedullary support instead. So you can see here, we're making our measurement. We are trying, I prefer right now to keep it within the zone of the plate. I tend to use the IlluminOss as an adjunctive support and not the primary support to resist deforming forces. So this is the squiggly line of the IlluminOss as it's going in. You can see it's got plenty of room. The X-fix is out of the way. There's no crossing screws right now. Although we also could have put in some of these proximal posterior screws and then would have been out of the way, just like another nail. And then we inflate the nail here. So you can see the polymer inflating. We've kept the height just about on top. And then here, this is where you wait. You put on a little bit of music, do a little dance, and now you cure it. And then you just fill in the rest of the screws. So all of these screws are engaging the device, the IlluminOss device here through the screws. So it's basically quadricortical fixation, which, we do that in the ankle all the time now for syndesmotic fixation in elderly patients who are going to be weight bearing. And I was hoping to achieve that, and I did. He had this separate tubercle fragment, which we tried to grab as well. The inferior screw is grabbing the IlluminOss, the superior one here. It was just missing the IlluminOss, and we allowed him early weight bearing because we knew that trying to restrict him would really not be that successful. And so he's relatively early on, but he's walking now. And this was his last set of x-rays, which was 4 weeks ago. So he's coming in next week for another set. And you can see, interestingly enough, the screw that engaged the IlluminOss is not backing out, but the screw that did not get the IlluminOss is backing out. So I recognize this is short-term follow-up. I'm the first person to say, well, that's not very long. But again, this is just an example of how you could use it. And, so far things are going well, and we'll wait to see if it really, helps him in the long term. So another example here is a little bit more of a typical trauma type case. You've got this patient, he's alcoholic, was hit by a car, has this extremely comminuted proximal tibia fracture. So even after spanning, he's got a massive bone defect. So this is another, concept, and I think area of utilization for IlluminOss. There's the 3D scan here, multi-column, fragmented. And then once you get past the shell of the tuberosity, it's just a giant hole. So ideally you would have, something, even after you get everything fixed and lined up, you need to somehow provide some support in the middle. And our options are fibular shaft allografts. Those have been described. You can use, all sorts of cement and putty and sorts of things. I was hoping for something that would be structural. So when you loaded it, it actually would support the bone underneath. And the challenge with some of these injectable cements is that if it's not a purely contained segment, you've got some areas of missing bone, it just puddles out everywhere. It's very difficult to manage intraoperatively. So I thought, okay, here might be a good way of a contained structural support that can be inserted in sort of a off-axis way, because as you can see, the start site for the nail really here is not an option. So, I went ham on it in a trauma fashion, lots of little mini frag plates to piece everything together, medial lateral incisions, which, I'll talk about that in a second. And then here's where the IlluminOss I thought was very helpful. So kind of pulled all the little cortical fragments down, started buttressing my pieces, kept the screws out of the way, and then using the nail in a retrograde fashion, which is not something we typically see in the tibia, almost like a retrograde metaphyseal support, like what I've seen in some of the pictures that they were showing earlier with a distal radius fracture. A metaphyseal defect is a metaphyseal defect, so use the similar approach. This is one of the larger ones that's more like a balloon, and it's tapered. And so you can see the size of the defect that this is filling up, and then the plate is really just rafting underneath the joint surface. So this is the post-up film. He did end up actually needing a gastroc flap because that medial side between the surgical exposure and the fracture dissection, it wasn't closable even after a couple vac changes. But then here he is at 3 months follow-up. He's been walking on it. He started walking on it as soon as the wounds were healed, and he has not lost any of his alignment. And so far, everything looks like it's holding together. So I think that's sort of another use. So those are the principal uses I have in the lower extremity, is some sort of columnar support or intramedullary void filler that is also structural and load bearing. And then sometimes when I have things where I wish I could nail it, but I need a curvy nail. For example, deformity. So here's another patient who was hit by a car and had this prior tibial shaft that was treated, I think, appropriately so non-operatively and healed quite well about 15 years ago. But then with this very displaced distal tibia fracture that goes just within to the physeal scar and a little bit of a Chaput fragment there in the front. So you could say, well, you can't nail it. Normally I would nail this and without question. So, maybe you just want to do a single plate. Again, getting into that concern over having just a lateral plate. He's already sort of predisposed to fall into varus. So I think if you were to just do this isolated plating, you would need to have a medial sided support as well. And here you can see that skin has basically just one dermal layer where is left. And so I'm a little hesitant to make an incision on that side and put some hardware underneath, because that skin there, again, you can't do gastroc flaps very easily. If that skin dies and you have metal that has to be there, you're really committing the patient to a free flap, which is, pretty morbid and pretty complex. So I, again, kind of went with my nail plate approach, except my nail is very curvy. So got a reduction provisionally with this plate. Everything's out of the way, and then sent up a retrograde nail through the medial malleolus and was even able to get very cute and do lots of blocking screws to bypass the deformity from before. Now, you can argue that might be overkill. I was thinking from a trauma standpoint, well, it's nice to have something that passes the stress riser, which if you stopped everything right at the deformity, that might be an increased stress riser. But then you can see here the nail kind of curving around. It fills up the volume that is available to it, and then finishing it off with a simple lateral plate. And then again, immediate weight bearing. And you can see there, that's the medial incision that we used. That's 2.5 weeks later. So that's a lot for the lower extremity. And I put a lot of emphasis on weight bearing, weight bearing, weight bearing. And it's not isolated to the lower extremity. Sometimes you have upper extremity situations that really need to be able to withstand some load, even though that's not traditionally what we think. And I'm going to share a couple of unusual cases with that, primarily in the proximal humerus, which is, where I have started using it the most. And I've been preferring it as my intramedullary fixation instead of a fibular shaft, and for a couple reasons. One, the fibular shaft is a little bit finicky to contour and shave down, and you have to have it match the diameter of the humeral shaft. So sometimes you're spending about 30 minutes burring it down, cutting it, shaping it, and then getting it in the right place is hard. It's not easy to drop it down from the top, and getting it, basically cracking open the bone to get it in one side and then over the other is also technically quite challenging. And so I've been looking for ways of finding intramedullary support for the humerus that are simpler. And if you talk to colleagues in the shoulder world, they hate it when they're converting to an arthroplasty and that fibular shaft is completely ingrown. So they've got like a double canal that now they have to burr out. So I'm trying to be a good colleague also in that way, and maintain friendships. So again, when is it that the upper extremity is weight bearing? Well, in sometimes the elderly and polytrauma patients. So I'm going to share some cases about that. So this is a 78-year-old man, terrible glenohumeral arthritis, but was very functional with it. Never really, was not planning on getting a shoulder arthroplasty, very independent. And during his fall, he also had a pelvic ring fracture and an isolated greater trochanter fracture. So was going to need a walker to get around. And this would be a very difficult nail for me. He's got a stiff shoulder. You'd have to open it anyway just to control the head to get that nail down intramedullary. And so I thought, but I didn't think a plate by itself would be able to withstand physiologic, essentially weight bearing. So I kind of went with that plate nail construct, and you'll see a little bit of a theme here. And he's 100% displaced. So, why not just treat it non-operatively? Well, He's 100% displaced. Also, his joint doesn't move. So I was pretty convinced he was going to get a pseudarthrosis there if we left it alone. And then then again, he's also not able to weight bear. So got my plate on. And actually I did sort of a MIPO type approach, an anterolateral deltoid split, and then plus a distal anterolateral approach to watch out for the radial nerve. And so again, using the plate to hold my reduction, getting my wires and screws out of the way. And you can see there distally, we've got it fixed. And then the nail becomes quite straightforward. You've got a nice little awl, kind of avoiding the acromion, dropping it down, the IlluminOss here. And then you can see just drilling and filling, just drilling right through the IlluminOss. So you have this I-beam construct now that is really about as strong as you can make it. And if anything, probably stronger than his original bone. He was immediately weight bearing, immediate full range of motion without restrictions. And this is him at 3 months. Those are his incisions. And then you can see he's pretty much the same range of motion as his other side, which is also arthritic. So he was very happy with this and very happy when he was told, yes, you can use your arm right away. So this is another similar patient, older gentleman visiting from overseas, not in the best of health, also very large. So he was in an Uber and was hit by a car, and that's why he's a real polytrauma, not just like a geriatric polytrauma where they fall out of a chair and get 18 different fractures like, we often will see. So he had a real need to be early weight bearing. He wasn't going to be braceable. And again, a tricky nail because you can see the fracture line here extends all the way up to the greater tuberosity. And I'm a little hesitant to allow people to weight bear on a nail when it involves the tuberosities. So I did an acute total hip on him, fixing the posterior wall as well, again, so he could weight bear lower on the lower extremities, but he's still going to need to pull himself up and push up on a walker. So I used a similar strategy for him. So same thing. Anterolateral split, got the alignment, dropped the nail down. There's a little fracture reduction finger that you can use to navigate some comminution. None of that comminuted area was exposed distal. And this is what is really interesting about this implant, because the modulus of elasticity is a lot less than a typical nail, even after the implant is down and cured. So you can see his incisions there. That's an actual patient. I was able to suck some of that over using a screw to just pull everything into a little bit of alignment for some stability after the fact. It feels like a little more malleable than like a stainless steel recon. So, I mean, there's structure there, but there's some correctable flexibility at the end. And so he went, and again, here he is at 8 weeks. I just saw him last week when he was at his 10-week mark. And you can see here the fracture alignment is maintained. And so, I think I see some early callus. I don't like to be, it's a little bit hard with his soft tissue envelope, but this was something where he was going to need to be fixed because he was not a braceable candidate as it was. So one more example here. Here's a younger man, also a polytrauma. He had a brain injury, was wild in the ICU, was not going to be able to follow. Similarly, your start site, you've got this greater tuberosity fracture line extending right up to the edge of the head near where your start site for a traditional nail would be. And so I took that same approach here where you've got the nail down. He's 4 months out now. Again, immediate weight bearing without restrictions. And you've got excellent callus forming here at multiple sites along that area of comminution, and similar sort of a MIPO type approach. If you notice, he had a dislocation, which is why I went with a deltopec approach rather than a deltoid split approach, but similar outcome here. And there he is at his 4-month visit. And you can see his shoulder's stiff because he hasn't been super compliant with his physical therapy, but it hasn't failed and it's healing. So I consider that to be a win. So, where we are with, where I am in my personal practice with IlluminOss, it's basically where I would want a drillable nail. So I just did one literally this morning on a patient who had a distal femur fracture with a total hip above. So these interprosthetics are becoming more and more common. And they're almost always in elderly patients who need to be weight bearing early. We know that for elderly people, if you're recumbent, or anybody, if you're recumbent fully, And in a medical condition, you lose 1% of your muscle mass a day. So for older patients who are already got sarcopenia and they're a bit frail, they don't have a lot of room to go. So we really put an emphasis on early mobilization. So where I want a drillable nail that I'm going to augment with a plate, for multi-column to support that, my first thought now is, okay, is this something where I could use an IlluminOss instead of a traditional metal titanium nail? And then, areas where you maybe want to do an intramedullary fixation, but there's some deformity where you can't quite get it, a traditional nail is not going to work without something dramatic like a clamshell osteotomy. For example, I've used it in other cases for OI patients where they don't have a normal canal and it's already in a lot of deformity, and a regular nail just wasn't going to work. So that's just my personal experience. I think it's a good tool to have in the toolbox. Is it a panacea for everything? I don't think so. I don't think any implant is. But I think as an adjunct to a lot of complex fractures or complex areas where need some really complex bone support and fixation options, it's a really good option to keep open. So I appreciate your guys' time. Thank